Welcome to our YouTube channel. Today, we'll discuss an interesting clinical scenario that will help you understand the diagnosis of a common autoimmune disease. A 22-year-old female presented to the ward with fatigue, intermittent low-grade fever, inflammatory polyarthritis, oral ulcers, hair loss, and a rash on her face for the past few months. Examination revealed a butterfly rash, mild synovitis, and oral ulcers. What is the likely diagnosis? Let's discuss the answer.
So when you listen to this patient story, you can see some obvious symptoms of autoimmunity, like fatigue. Then intermittent low-grade fever, so she gets fever time to time, and inflammatory polyarthritis, oral ulcers, hair loss, and skin rash, right? So there are some obvious clinical symptoms, right? So you get suspicious about, okay, what if this patient could have something related to autoimmunity? What is autoimmunity?
Our own immune system attacks our own cells in the body.
Yes. So usually immune system is assigned to attack the foreign cells, but in the case of autoimmunity, the antibodies are trying to attack our own cells. That's why this patient is getting these kind of things. It can attack the muscles, it can attack the joints. Now lots of things are going on inside this patient, right? So specifically in females, the chance of getting autoimmune conditions is high, right? So now you need to confirm your diagnosis. So one of the basic tests, basic investigations that you can request to confirm your diagnosis is called as antinuclear antibody test. In simple terms, we call it ANA, right? So usually those antibody tests or immunological assays, they are a bit expensive. Sometimes they might not be available in the government hospitals. You might have to send the patient's blood to a private lab, or you might have to refer the patient to a private hospital. So this ANA test is a basic test which does not cost that much. You can use to do the basic confirmation whether this patient is having autoimmunity or not. Not whether that this patient is having arthritis, SAD, not likewise. Just to check whether there is autoimmunity or not, you can request this test, right? So this is a microscopic method, right? First I will show you how it is done. So this is the simplified version of how it is done. So these are glass microscopic size, you have seen, right? The microscopic size that we put into the microscope. So they are commercially made by coating a lab-grown human cell wall, right? So they have pasted a cell layer on the tissue and you have to purchase that particular slide. And then when you add the patient's serum, do you know what is the difference between serum and plasma? Yes? Yes, very good. So in the plasma, it is a liquid portion of the blood now. It usually has the clotting factors, or from factor 1 to factor 2. So when you let the blood clot for a while, all the clotting factors or the proteins get consumed by the mechanism. So after it is removed, you will be left over with the immunoglobulins. So you take that serum and you have to dilute it, right? Dilute it, and then when you add it onto the cell, the autoantibodies, if it is there in the patient's serum, they will go and bind to the cell's particular site. So there are autoantibodies that could go and bind to the nucleus. There are autoantibodies that could go and bind to the places of the cytoplasm. It could go and bind to the mitochondria, then the Golgi complex, transport vesicles, or the cytoskeleton. There are lots of components which they go and bind specifically. Okay? So now, after the autoantibodies bind to the specific site, we need a method to visualize, right? So for that, we use an anti-antibody. Anti-antibody means an antibody designed to target another antibody. So this Y-shaped probe is antibody. This probe will come and bind to that antibody. So the tail of that antibody, we have marked it using a fluorescent form. So do you know what fluorescent does? Usually fluorescent stuff, they can absorb a certain wavelength of light and reflect it. So here they put this light under a UV microscope which has a UV light, not the normal light, right? So they absorb certain wavelength of that light and reflect back a beautiful green color like this, right? So I will show you one of the basic patterns. Here, look at this picture, right? Do you see these green color circles? Those are actually the nuclei of the cells. Now you don't see any other cell demarcations here. You will see only these green circle things, which are the nuclei. The nucleus is between the cells. So then autoantibodies, whichever they have put in this patient, it has gone bound to the nucleus of the cell. So we report in the report saying that this patient has a positive nuclear pattern. There's nothing in the cytoplasm. Cytoplasm means blood, right? So if the cytoplasm has some pattern, it will appear like this. Cytoplasm stains are different, right? So these are the the cytostatic time when it gets stained. Likewise, you will see something inside the cell, right? So cytoplasm is negative, and then mitotic pattern. Mitotic patterns are the autoantibodies that binds to the components that are expressed only during the cell division. You know the mitosis, right? So there are certain cellular components expressed only during the mitosis, like what? Yes, the kind of spindle fibers, right? So those are expressed only during the cell division. So during that phase, they go and bind like this. See, only the dividing cells are stained here. So that means those antibodies are gone and bound to the spindle level. Right? So this is how we report it. So when you request a report from the patient, right, the patient will return to you next day with a report like this. Right? Then if you see something positive, then your suspect regarding autoimmunity is correct. Then you can go for further investigation. Like there are further investigations like immune blotting, and also maybe you have, I don't know whether you have heard, there are methods called ELISAs. So they do specific testing which cost more, which takes more time, and they can do further investigations to find out what specific antibody that could be. Now, if a certain pattern gets positive, we cannot specifically predict the disease from them, right? So now, from all the patterns they have observed so far, right? The immunologists and researchers all over the world, they have put together all the patterns into a nomenclature. We call this as the ICAP nomenclature, International Consensus of Antinuclear Antibody Patterns, right? So they have categorized this from AC1. AC is just the code that they use, AC1 to AC29. They have basically divided as nuclear pattern. Negative ones are separately named as AC0. All the positive ones, they have divided into three basic groups: nuclear patterns, cytoplasmic patterns, and the mitotic patterns. So under the nuclear patterns, there are sub-patterns that you can look into: AC1, AC2, AC3, like that. So there are certain autoantibodies that could go and bind to the double-stranded DNA found in the nucleus. That can go and bind to the centromere. That can bind to the nuclear envelope. So that can bind to the nucleolar, right? So when those antibodies go and bind, they give a distinct pattern. So when you look it under the microscope, if you have trained reading ANA patterns, then by looking at the slide, you know what this pattern is. Whether it's AC1 or AC2 or AC14 or AC15. There can be mixed patterns as well. Sometimes, there are two or more patterns seen in patients. So even in that case, we can distinguish. So the most important thing is, you have to see what pattern is positive. If it's all negative, then there is no autoantibody seen in this patient, right? And another important thing to read in the report is N-titer. Titer means how much will dilute the patient's serum. So if this N-titer, usually we take 1 in 80. we usually dilute 1 in 80 and 1%. If there's lots of autoantibodies in that patient blood, let's say there's high concentration of autoantibodies, then you will not see something clear like this. It will get like all over the place will get stained in green color. So you cannot read the pattern. So we further dilute it, right? If you have to further dilute it, what does that mean? There's lots of antibody. Concentration is high, right? So this patient has gone up to 1 in 1280. Then that means this patient has had lots of autoantibodies, right? So if it is positive in 1 in 80, we consider it as positive. If it's negative in 1 in 80, then we say it's negative. Usually negative patterns are like this. Cells peenawa, but no clear pattern. Right? You don't see anything clear. Positive now, මේ වගේ පහදලිව හොඳට fluorescence pale. You will see the fluorescence pale. Do you see the difference? So we try to do it 1 in 80. If it is with no fluorescence, we start from 1 in 80. 1 in 80. 80 तम start कराने एक positive ना. If it is too much bright or the fluorescence is too much, then we go for dilution factors. We dilute the serum. So now the clinician can get a picture about like what level of autoimmunity could be there in this test. There is autoimmunity. Then how much level of autoantibodies are there in the circulation? If the titer is high, then sometimes the doctors specifically request for the titer. If the doctor doesn't specify titer, we just do it 1 in 8. So by the time, with time can these antibodies increase? Because the antibodies also have yes, you can see. Antibodies also, they have a lifespan, so they could go back and forth. වැඩි වෙන්නත් පුළුවන්, අඩු වෙන්නත් පුළුවන් with time.